Now we're going to talk about, we already talked about what kind of patients are coming to us, why we exist, what psych emergencies are in general. Now we're going to talk about what we actually do here and how we're going to work with our folks to help get them better, and what our philosophies and treatment approaches are that's actually going to work, and we're going to see great responses because it's just the way things are going to work. So I kind of call this moving beyond Haldol because those of you who know about even some of the names of any psych drugs know that the patients going into the psych ER, or those guys that we saw at Katrina, they'd been given what they call like the Haldol cocktail. And the Haldol cocktail is very strong and it knocks people unconscious. And as we said earlier, we don't want to knock people unconscious because that's not helping them, and that's certainly not moving anything along in a nice way. So let's move beyond Haldol and talk about different ways and the kind of ways we're going to approach treatment here. So just in general, when we're going to be starting meds here in a CSU psych ER, we want to give meds by mouth if we can. That makes a lot of sense. Instead of holding somebody down and giving them a shot against their will, encouraging somebody to take meds willingly, there's that therapeutic alliance. How much are you going to trust somebody who holds you down, has 5 staff hold you down, and they stick a big thick needle into your naked rear end? Is that somebody later you're going to go, gee doc, whatever you say, I trust you completely, you know? You're going to not have much of a therapeutic alliance. So it's worth trying to encourage people and collaborate with them to take a med by mouth, because then it's their decision. You're not forcing them to do anything. And it's even better for the staff because although a lot of ERs would just say, oh, it's easier to give somebody a shot. You know what, if somebody's kicking and screaming and you're trying to hold them down and give them a shot, what happens sometimes? You get kicked, oh, wow, there goes the needle, ouch. Bad things can happen. The other thing is if you do give antipsychotic medications, what we want to do is use the more modern ones, the ones that have come out pretty much in the last 15 to 20 years, because these medications are used to calm people down. They're more like a chill pill than a knockout dose. That old method of these people are agitated and threatening and violent, let's knock them unconscious. Instead, we've got medications that just help them calm down. And isn't that better than knocking them out? Because if you've got somebody who's calmed down, well, I'll talk more about it in a second. What happens with that old-fashioned Haldol cocktail, the Haldol and Ativan cocktails, you knock people out, sometimes for 12 hours, sometimes 18, sometimes 24 hours. Sometimes they're so knocked out, you can do the most noxious stimuli that we use in medicine, which is take your knuckles and rub on your chest plate, your sternum there, which don't do it because it really hurts. And if you do that to somebody who's even pretty deeply asleep, they're going to go, ow, crap, what are you doing? They'll wake up. If you can do that to somebody and they don't wake up, they're really unconscious, and that's what's usually like from that Haldol cocktail. That means they're not going to be waking up for a long time. You don't want that. You want people to calm down rather than be knocked out. We'll go into that more in a little bit later. Ativan, lorazepam, it's a medication we are going to use a lot in a place like this. Why? It's a medication that helps people relax. It makes it really easy for you to go to sleep. By and large, it's fairly safe. You know, and there's no such thing as a safe medicine. They all have side effects, but this is much safer than most medicines. Even the best antipsychotic medication that we're going to be talking about later has some pretty serious risk factors. So there's never a good reason to give somebody an antipsychotic medication unless it's clearly indicated. Some doctors will say, oh, they've been using lots of meth, let's give them an antipsychotic medication. Why? As soon as you've calmed them down, they get some sleep, they're going to be better. They don't need to, they go, well, the antipsychotic works. Yeah, so would like not doing anything. You know, it's because it's the time, it's the sleep that's going to help the people get better. So what we want to do is use medications wisely. What we can do is use Ativan. It helps people relax. It helps people to sleep. They can fold out these chairs here and get a good nap in sometimes. The only thing we're concerned about with a med like that is it's also pretty pleasant, and sometimes people are going to be asking for it. Sometimes that's to your advantage, because sometimes I've seen patients who will come in and we'll find out that they're they're not in very good control, and we find out they'll say that they've been using heroin, methamphetamine, ecstasy, LSD, cocaine, marijuana, alcohol, and a few other things from the pharmacy. And you'll say, we'd like you to take a little medicine to help you get better. Oh, not me, doctor. My body's a temple. You know? And then you say, well, you know, Ativan, it goes for about $5 a hit on the street. Oh, okay, well, I'll try that then. So Ativan even has a popular kind of street cachet. But so it's a good medication for short term, helping people to sleep a little bit, help them calm out. Maybe the CSU's best friend. We don't want to give it people too much because it's also kind of popular, like we said, and they can sell it on the street. But for short term helping out, it's a medication we're probably going to use a lot. How about antidepressants? Here we are for 15, 20 hours. Is there a reason we'd want to start people on antidepressants? Well, remember I was talking about before that those antipsychotic meds, they were telling us it took 4 to 6 weeks to work. We know that's not the case. Guess what, though? It is the case with antidepressants. They take several weeks, usually a month or more, to really work. Sometimes you'll start seeing an effect in 10 days, 2 weeks. Anyway, we're talking about 15, 20 hours here. We're not going to give somebody an antidepressant and they're going to suddenly be happy. And even the antidepressants are not supposed to like make you happy, but make you more amenable to pleasurable activities, make your sleep better, make your appetite better, things like that. There's not a lot of reason for us to say, okay, out of the blue, we're going to start an antidepressant. We're going to give it to you now urgently. There's no urgent antidepressant. Maybe not too far in the future. That's another story. There's some interesting research going on right now. But as far as right now, there's no reason to do this. If we're going to admit somebody to the inpatient unit, we might want to start the antidepressant here because it's the first day and we'll get them a little head start. But if somebody says like, doctor, or you're talking to a family member, let's say, and they're like, well, they were here and they were having suicidal thoughts. Didn't you give them an antidepressant while they're here to help their suicidality? And it's like, well, that's not, we can start them on an antidepressant. We'll give you a prescription for it, but it's not really going to be something that's going to change the world while they're here. So that's just to understand, it's a different kind of medication. There's not a lot of use for it in the psych ER. There are some interesting ways that we give meds in emergency psychiatry that are a little different than what we're used to doing. Both Risperdal and olanzapine, which is also known as Zyprexa, come in a fast dissolving form. Risperdal is called the M-tab, Zyprexa is called Zydis. We'll use a lot of it in a place like this. The reason being is it dissolves in your mouth, goes right into your system. It's much faster than the regular forms of this meds, faster than anything except the shot. And once people take it in their mouth, they really can't spit it out. So they can't pretend that they took it and then hide it in their corner of their mouth like they could do with the pill and then spit it out later, like you've seen in TV movies. They don't know, I hid the meds. No, you can't do that with the dissolving meds. But the main reason we like them in the psych ERs is they work a little bit faster than the regular, usually about 15 minutes faster than the regular version of the pill, almost as fast as a shot. There's actually a med that's so new and it's expensive, we won't be using it here, but there's one that you actually put under the tongue that actually goes straight into the bloodstream. I don't know how great that even is for an ER because that one doesn't work if you do swallow it. So the way to actually take it and make it not work is to swallow it. And if somebody knew that, then they'd be like, okay, I don't know, that's good. There's actually inhalable psych meds now. It's expensive, it's not very widespread. They use it a lot in Europe and South America, not so much in the United States so far. The neat thing about it is that somebody who's psychotic and agitated, it can make them better in 2 minutes. Again, here's stigma about psychiatry. Because the med costs about $100 a dose, every hospital said, like, well, what do we need that for? We can give people a shot, and they'll be better a few days later. That shows how much they really think about that worst headache in your life. I mean, if you came in and you had, like, broken bone, you could fix it in 10 minutes for an extra $100, do you think that every hospital in the country wouldn't do that? Of course they would. Psych patient comes in, you can cure them almost, technically cure them in 2 minutes. Nope, too expensive. We've got something else that only costs 50 cents. It's very sad. The main two meds so instead of using that Haldol shot that people have used for 50 years, our preference here is going to be for two medications that get rid of a lot of that agitation, that psychosis, the anxiety, the paranoia, and helps them relax but doesn't knock them out. One of them is intramuscular olanzapine, that's IM Zyprexa. The other one is ziprasidone, that's IM Geodon. Those are be ones that if you do get to the shot level, which hopefully we'll avoid 90% of the time or more, when we do give a shot, we're going to be using Geodon probably more than anything else. Geodon, at my old site in Oakland, they called it, the nurses called it the magic bullet. Because if somebody got a shot of that, an hour later, they were like, hey, I'm doing so great. I'm eating a lunch tray, you know, instead, and they were not sedated. In the olden days, they would have gotten that Haldol Ativan cocktail, they would have been out cold. And sometimes we discharge them an hour or two later after that, they got that much better. That's what's neat. So, calming techniques, and this is a big thing that we do as well. So there's medication that help people get better, but we can also help people calm down by our own little interventions. And this is the best thing that we can do as any kind of clinician. And everyone can do this from security on up to the docs. Can we help people relax? Can we show them that it's okay, that they're safe? What kind of things are they looking for? What kind of things will meet their needs? How can we make them better? Much better than putting them in that chemical restraints like we talked about before. So, what we do need to understand, though, is agitation is a real emergency. Here's the kind of things that we describe in agitation I was mentioning before. Somebody's very hyperactive. They've got a lot of energy. They may be aggressive. They may be verbally abusive. They may be calling you names, sarcastic. You know, there's a spectrum with agitation where people go from they're just kind of irritable at first, and they start saying, wow, the staff here are all idiots. And what? Doctor is ugly. And they're like, yeah, what else you got? You know? And they get all the way up to where they might be kind of even starting to clench their fists or pacing about. And then the staff might saying, doctor, you know, this person's really starting to get agitated. We better do something. This is a really, really common thing in ERs, psych hospitals, any kind of treatment facility around the country. Latest estimate, 7 million times a year that people are agitated in hospitals. Mostly in medical hospitals, also psychiatric hospitals. That's an enormous number of times of something happening. You know, if there's other diseases, if they happen 7 million times, you would be wearing a ribbon on your clothes for it, or you'd be going to the fun run, or there'd be a telethon or something like that. You know, where's the agitation fun run? They never have that, right? It's a big, huge thing. So it's a serious situation and needs to be paid attention to. But the best thing about it is that we can actually intervene early and prevent a lot of serious agitation. What we want to do is, like, you know, people can get agitated from a lot of different symptoms of illnesses. What we want to do is really intervene when they're at that low end, when maybe they're just starting to get irritable or hyperactive, long before they've gotten aggressive, certainly before they've gotten violent. And when we can do that, we can often do that in such a way that will involve medicine to help things kind of taper off, but a lot of it's also just in the way that we intervene. So I've actually been doing this now for over 30 years, as I mentioned, and I think I've worked with something like 85,000 emergency psychiatric patients, and about a quarter of those had agitation. And basically through the time it's like we got to, like I said, when I was leaving my last site, we were putting less than 1 out of 1,000 people into restraints. Less than 10% ever needed coercive medications. So it's all possible to do. Just this past month, I have to give a plug in. I have a new book out. This is Textbook of Agitation. So agitation is obviously an important thing to me. 292 pages, hardbound, from the good folks at Cambridge University Press of London, England. Available at Barnes & Noble, Amazon.com, and finer booksellers everywhere. So, agitation is a big deal. We already said it's 7 or 8 million people. What happens if you don't intervene in it? Well, bad things happen, unfortunately, and sometimes people get hurt, and sometimes they get hurt really bad. 8 to 25 people at emergency departments, psych hospitals a year at one point were getting hurt by agitated patients. And when we say hurt, not just like somebody took a swing and missed, it's like hurt enough that you missed work. And some people, I had really good friends, nurses, colleagues, doctors who never went back to working in emergency care because they had such a bad experience with agitation, really serious. It's possible, but as I was mentioning before, the vast majority we found in our research of injuries and bad things happening to staff happen during the point where somebody says, that person's acting up, let's tackle them and put them into physical restraints. And because people, the average person said, you know, and I've talked to people like when we were putting that book together, they say, oh, you're always talking about reducing the use of restraints. Unless we put these people into restraints, we're in danger. It's like, no, you're in danger by putting them into restraints, because say you're paranoid and you're having a difficult time and you have 10 people coming at you and you know they're coming at you to tackle you and restrain you to a bed, spread eagle, and then give you 3 needle shots in your bottom. What are you going to do if you're already not thinking very clearly and you think that 10 people are coming to make that happen to you? What do you suppose you're going to do? Fight, right? You're going to fight or you're going to run. Either way, yeah, you're fight, and then what happens? Then people get hurt. So what we found out is that 2/3 of all staff injuries happened during people trying to put patients into restraints. So then we said, like, hey, I don't know if I'm a genius on this, but maybe if you didn't put so many people in restraints, there wouldn't be so many injuries. And people are trying to say, oh no, unless we put people in restraint, we're going to get injured. I'm like, no, I think putting people in restraints is why you're getting injured. And indeed, that's been the case, and we've seen that. And what we've seen from our research is that putting people in restraints is not only bad for the staff, but it's really bad for the institution. It's bad for everybody, certainly bad for the patients. Just putting somebody into restraints costs that hospital $350. 25 different activities on staff, 12 different hours of staff time when you add in all the different people who've been involved in putting somebody in restraints. Like I was saying, you have staff turnover because bad things happen to people who end up putting people in restraints. And even insurance companies will base the insurance policies cost on how often you put people in restraints, which is something I found was fascinating. I looked at it. Being in restraints just seems like bad enough to begin with, but it's kind of hard to understand. Maybe it sounds like, well, if they're a dangerous, agitated person, maybe that's a good place for them to be. But we didn't think that. So at my old site, when we had a new doctor come in, the way that we would train them, as part of all the rest of their training day, one of the parts was we would take them into what they call a restraint room, and we would put them into 5-point restraints, tie them to a bed, turn the light off, close the door, and leave them in there for 10 minutes. And then come back and say, how was that? And just about everybody said, that was horrible. I hated that. I don't want to go through that. I don't want to make people go through that. Now, there was one guy who said, with candles, wine, the right person, that might have been kind of cool. I don't know how well he ended up doing. But overall, it's not a good thing for the hospital. It's not a good thing for the staff. Staff feel bad putting people in restraints. They can get hurt doing it. But it's clearly not a good experience to go through yourself. So a lot of places have said, we need to change this. And for the last 15, 20 years, there's been a lot of advocacy and also federal regulations trying to reduce people being put into restraints. But even to this day, in this modern age, people are still doing, by and large, if you're angry or you're looking at somebody in a bad way, especially in ERs, you're still going to get what we call restrain and sedate. You're going to get tied down to that bed, and they're still going to give you that Haldol cocktail that knocks you out. Even what I've all told you, and you can understand why it doesn't make any sense to do it, and there's all these other meds. The majority of ERs in the United States still knock people out with Haldol. And I still get in arguments with ER doctors who I say, look, there's so much better way to do it. And they're like, well, Haldol's always been fine for me. Since you're not the one getting the med. why is it fine for you? And they're just really fixated on it. They're like, that's what I've always done. But we felt that there needs to be a better way to do it. And so we got involved in it. This is not a new idea. 14 years ago, the Institute of Medicine said it's not acceptable for patients to be harmed by the same healthcare system that's supposed to offer healing and comfort. Why would we be restraining people when we're trying to help make them better? Doesn't make any sense. So how have people addressed this? Well, over the last 10, 12 years, there's been agitation guidelines. Several different programs have tried to take this on. Mostly, though, they were just saying, like, once you get that person into restraint, what medication should you give them? So they weren't even addressing that part of it. So in 2012, I put together, I was president of the American Association for Emergency Psychiatry, and we put together a multi-center study with over 40 emergency psychiatrists, emergency medicine docs, nurses, social workers, hospital administrators, even a patient rights attorney. We put them together into this big project. Let's figure out the best way to work with people with agitation and hopefully avoiding restraints, and hopefully avoiding inappropriate medications. So we put together Project Beta, which Beta, the BETA, stood for Best Practices in the Evaluation and Treatment of Agitation. It was actually based on, you've heard of this guy's 6 goals. Based on the 6 goals, we put together these 5 work groups about medical evaluation. We know how important that is from the goals. Psych eval, what meds are, how to avoid restraints, and the centerpiece, de-escalation, something that anybody can do. And it's even when you're doing all the other things and working with somebody with agitation, you're always going to be doing de-escalation. De-escalation, basically, in simple ways, is just helping somebody to relax, helping somebody to calm down. Escalate, going up the escalator, that's getting more angry, more escalated. Going down the escalator, de-escalating, that's calming down, it's relaxing, it's getting better. So we actually published these as all 6 articles, so the 5 work groups, and then an overview article. We published them in an emergency medicine journal in 2012 with enormous impact around the world, which has been just tremendous. So they're the most downloaded and the most cited articles in the history of this emergency medicine journal. The de-escalation article alone has been downloaded over 50,000 times, which is amazing when you think that there's 5,000 ERs. So that means like 10 people per ER downloaded the article. And the medication article has been cited in other scholarly publications close to 200 times. So these were very, very impactful studies. We had a whole section of this emergency medicine journal, and it's had great effects. It's now in play. The Project Beta guidelines are being used in hospitals on 5 continents, which is really cool, and thousands of patients have had things about it. So what are these, real quickly? What are the Beta guidelines, and how do we do things? So again, agitation's an acute behavioral emergency, but rather than tying somebody down and giving them shots, what we want to do is help them to calm down, de-escalate. That's our preferred intervention. Medication can be part of that intervention and shouldn't be thought of as like it's the either or. They're actually both part of the same thing. Part of it is saying, hey, you're going through a tough time. You know what? Maybe some meds will help. Here's some medicine that might help you. A lot of the people, when you talk to them afterwards, and what an amazing thing when people are agitated is you might think, I've heard doctors say, well, what difference does it make if you restrain them? They're so out of it, they'll never remember any of this anyway. Actually, if you do the research, the people who've been agitated remember everything with crystal clarity. They can tell you every detail that happened. And one of the things that they always say when you talk about it is they say, here's the place that I lost control. So losing control is the big part in the way that they perceived caused their agitation. So that makes you think, well, we want to help you regain control. And how do you help somebody regain control? And that's what's really possible about it. So one of the parts about helping people regain control is giving them autonomy over their own situation, agency, if you will, ability to make decisions about themselves. Offering medication, we think that this might help you. Do you want to take this? Yes or no? Yes. That's making a choice. That helps you regain control. You're directing your own path, if you will. We want to help you avoid getting restrained. Maybe if we have you go over to one of our calming rooms, like we have here, we can go and sit there and help get things better and talk about what's going on, or give you a chance just to chill out and get away from the room. That's de-escalation. That's helping people regain control, make choices, make decisions for themselves. Well, I just said that. Helping the patient regain control. But you can also be evaluating somebody. It doesn't mean that you're just focused on it. One of the things you find working in a unit like this is that you wear a lot of hats. And the one thing that you can never say working here is that's not in my job description. Because everything's in your job description. Because whatever it takes to make sure that patients are doing well and getting calm and healing and getting better is part of your job. All of our jobs. And so helping people to get better is all based around de-escalation, but you can also be doing your eval and writing a note and mentally thinking about how you're going to document things while you're doing it. There's no either or. Everything's part of the overall work. Kind of like this schematic. You can do your psych eval, your medical eval, you can give meds. Everything revolves around de-escalation, and that's the key to avoiding seclusion and restraint. So, how do you learn how to do this? It's actually, de-escalation is an extremely simple thing. It again goes back to what we said in the first part, following the golden rule. Treat others as you'd like to be treated yourself. Understand that people are going through a tough time and don't yell at them about it. Be understanding. Kind of that simple. And I've had doctors and staff in ERs tell me, it's like, well, this de-escalation stuff sounds good, Dr. Zeller, but we're really busy. We don't have time to do that. It's much easier for us just to put them in restraints and give them a shot. We don't have time for this de-escalation. Well, most de-escalation takes a few minutes at most, sometimes less than a minute. And instead, the whole part of putting somebody in restraints means getting a staff together, getting all things going on, getting security, finally doing it where you're trying to go at it, and finally there's a tackle, and then you're getting somebody gagging in the room, and then you have to get everybody together and hold them down and put them in restraints and all that, and meanwhile a staff member goes off and gets the medications together and comes back to the room and you got to get the staff together again and hold the patient down and then give the shot and all that. And how long did that take?
And then do the paperwork.
Yes, and do the paperwork as well. And then have somebody doing a one-to-one. When all you needed was a minute or two of some understanding and some compassion. You could have avoided all that you didn't have time for, right? And if you want to have a good experience, that therapeutic alliance with somebody, imagine somebody that you restrain versus not restrain. You're going to be the enemy, people that you restrain, right? They're not going to trust you after that. And somebody was asking before, what about if you have a hard time getting somebody into a program, if you got to transfer them? How many programs take people who are in restraints? Not very many. Some will say, we won't consider them until they've been out of restraints 24 hours. You want to get people moving along and help them to get to the right location? Restraints are something you want to avoid if you can. And it's not good for folks either. You talk to these patients, this is from our research, where in the olden days people just got restrained if they didn't want to talk. And somebody would say, will you agree not to be violent here? And the person just they wouldn't respond. Okay, put them in restraints. They're refusing to agree to a no harm contract. That actually used to happen 15, 20 years ago. Remember that a lot of our patients, and this is a concept you'll hear about a program like this, that we're trauma informed. Understand that a lot of the folks who have serious psychiatric conditions or that get to the state that they have a psychiatric emergency have been in emotionally traumatic situations in the past. Some have been abused, some have been neglected, some have been hurt physically. And you come in here and you start being coercive or trying to force people to do things, those memories flash back and that makes people aggressive or violent. So we really want to avoid that. So just being trauma-informed, again, is not some magical concept. It's understanding that most of our patients have had trauma in their lives and trying not to re-trigger that with them, if you will. Again, compassion, golden rule, being understanding. As this young woman said, I was abused before I was in psych care. Being restrained made me feel the same way. But the staff were supposed to help me, not hurt me, right? It made me worse. How's that supposed to make me feel better? Wouldn't it have been cheaper if they just listened to me? Sometimes it's just all that, just listening. That's de-escalation. Here's the real simple way. We've got like 10 minutes left, and I'm going to teach you all you need to know about de-escalation in less than that time. It's simple. If you have to remember one thing from today, if you only remember one thing from what this blowhard guy up here has been saying today, one thing, it is, if somebody is agitated, don't be agitated back to them. It's that simple. Sounds so logical right now, right? But what if somebody comes up and he's going, I'm going to kick your rear end, you stupid son, you know? And most staff respond with what we call the oh yeah method. Oh yeah? Bring it on. Right? So it takes a little bit of restraint on your own part, not physical restraints, to actually be calm and be understanding and say, hey, sounds like things are going wrong right now. What can we do to help? This is a safe place. I'm here to help, not to hurt. And there's even a stance that you can use. It's kind of in one part here. So you're non-provocative. Somebody else is agitated. You're not. Sorry about getting out of your camera there. But basically, there's an idea that you have your hands at your side. Maybe your hands open a little bit. What's that telling the person? Remember, these are all like subconscious cues. You're not actually like speaking to them with your stance. But by doing this, they can see that you're not ready to punch. What don't you have in your hand?
Nothing.
Weapons, right? Nothing. You got nothing in your hands. And you're kind of just relaxed. You're cool. Like, hey, look at me. I'm jelly. Yeah, yeah, I'm okay. I'm not going to hurt you. And then you can speak in calm, short sentences. Say, hey, what's happening? It's okay. We're here. This is a safe place. We're here to help. We're not here to hurt. We're here to help. What can we do? What do you need? And that's the kind of things that you add. And you remember that you give people a little bit of space. Remember the whole thing we were saying before about how when people get crowded, that it's uncomfortable and frightening? So it's the same kind of thing then. If you're having a tough time, the last thing you want to do is have the whole staff back somebody into a corner. We even have that expression, like a cornered animal or feeling like you're caged in or something like that. We know what that means. We don't want to do that to somebody. We want to give them some space, allow them to relax, allow them to know they're safe, allow them to know things are going to be okay, and then we listen. We establish verbal contact. We say, hey, what's going on? How can we help you? What do you need? What can we do for you? You use short phrases, you use short sentences. You don't try to be complicated. You don't try to make it like, you know, we had a guy here like you last week, and you know what happened that time? You've lost him. Simple things. What's going on? How can we help you? What do you need? You must be having difficulty right now. Is it tough? Tell me about what's happening. And then you listen. Identify their wants and feelings, if you will. You know, sometimes it's amazing working in settings like this that somebody, when you actually say, what's going on? Why are you so angry? And they're saying, like, I just wanted something to eat. Nobody would get me something to eat. I'm thirsty. I wanted a drink, and the nurse told me to come back later. I was cold. I needed a blanket. This guy over here is bothering me. I wanted to go somewhere else. I wanted to move away. Why won't anybody help me? Sometimes it's as simple as that. Sometimes people feel like they need to be agitated to get attention paid to them. It's one of the reasons that we like this model so much, because the staff are always very close by, and you don't have to be agitated to get somebody to pay attention to you. In fact, we'll notice if you're having a tough time, and that's the folks that will go and say, hey, tell me about what's going on. But listening is really, really important. So you see the law number 7 is you shall listen. And you don't argue. And remember that other people might be perceiving things differently than what you say. So you don't need to challenge them. You don't need to say like, no, there's no monsters here. Yeah, you say it in a safer way. Saying, wow, that sounds scary. but you know what? This is a safe place. You're okay here. And you can get some staff sometimes who actually like to fight and mess it up, and they're it's like they said, they have that oh yeah method. You're like, hey, bring it on, you tough guy, you know. And that's tough, and that's somebody that we want to make sure that we let our team know that there's an issue here, and we need to work with them on ways to make things better. And if that doesn't seem possible, maybe there's a different place they should be working. Because this is not the right kind of place for that kind of behavior. This is all about healing, this place. It's calming, healing, different approach to things. So you see it was like one of the earlier rules, but one communicator. It's kind of along the lines of what you say, especially if somebody else seems to be a little more having a difficult time or being a bit hot-headed. Maybe it's just kind of like, hey, how about I talk, you know? And then, like I said, you listen. You can agree to disagree, you know, and only after all else things have failed do you, even consider going into coercion. But what we have nice here is we have the calming rooms. So before you would get to the point where maybe in more historic setting we would talk about lock seclusion or physical restraints, we can have the staff suggest maybe we can get you over to the calming room, and we can go and sit in there, and I'll even sit in there with you for a while, and you can tell me about what's going on. You can get away from that person who you don't like the way they're looking at you. And we'll get you away for a while, and maybe you just chill out. And sometimes they only need a few minutes in there, and sometimes it's longer, but who cares? As long as they're doing okay and they're safe and you know that they're getting better. So the great majority of time, unlocked seclusion, the calming room is going to be all that it takes for somebody to calm down. If they won't stay in there and you have no alternative because they're going to be violent unless they stay in the room, then you can lock the door. That's locked seclusion, and that's for people who are a danger to others. That's all as far as you need to go. When you need to get to physical restraints, well, that person who's in that locked room who's a danger to others, they're not going to be able to hurt anybody else because they're in a locked room, so you don't need to restrain them. You only need to restrain them if they start hurting themselves as well, like the person who starts bashing the door, or hitting their head on the wall or something like that. That's how you can really reduce the number of people putting restraints, because it's always about safety and always about the patient's experience. So you only really need to restrain somebody if they're trying to hurt themselves and they can't stop themselves from doing that. And that should happen really, really rarely. And the unlocked seclusion, the calming room, if you will, should help the great majority of the people who in the olden days would have gotten restrained. And that's how that all works. So, medications for agitation, just so that you understand what these are. We've got about 5 minutes left. The goals of these medications are, again, get rid of that anguish, that worst headache you've ever had in your life. Make sure that people are no longer feeling the need to be dangerous. We're going to do it in such a way that we have the least side effects possible. And again, the goal is helping the people to chill out, not to be knocked out. By minimizing the side effects, using meds that don't cause bad side effects, and by doing things like collaboratively, like using oral meds rather than shots, you improve the chances of a therapeutic alliance. You improve the chances of the next time somebody being willing to reach out and trust docs, staff, clinics, whoever, and ask for help rather than thinking bad things are going to come. Right now, if you've been, the last time you had a psychiatric emergency and you went to the ER and you told the nurse what was going on, and what happened was the nurse called security, and next thing you knew, you were slammed to the ground, put into restraints, and given these 3 painful shots of this medicine that made you feel horrible and had bad side effects. Next time you're feeling that way, do you think you're going to say, hey, I should go to the ER, right? So maybe if we change that perception and we give people a nice, calming, safe, supportive, healing environment, maybe next time they'll reach out earlier and they won't even need to get into an emergency. And that's kind of the idea. What they're doing now, a lot of the times, they're so scared of what happens if they actually ask for help that they're waiting until it's too late, and then it happens anyway. And that's what we want to avoid. Again, medications aren't chemical restraints. They're used to calm, not to sleep. And we want to use oral meds over shots if we can. Somebody mentioned before that sometimes patients ask for shots. If that's really what they want, great, that's okay. We want to make sure that we're doing as much as we can collaboratively with folks. But most people don't really like needles, and they prefer to take a pill with a glass of juice than they would get a shot, and that's a lot easier to do. So medications, like I said, that you give for illnesses like with psychosis, like schizophrenia, mania, we want to give meds orally. And if we do give medications, where we're going to use is what we call the second generation antipsychotics. This is Risperdal, it's Zyprexa, it's Geodon, it's Seroquel. These medications tend to work really well. They have much less side effects than the older fashioned drugs like Haldol, Prolixin, and those drugs. And you can often combine those with our friend Ativan, and they can work really well by mouth. They work pretty fast, not quite as fast as the shots, but almost as fast. And so why would we use these over the old-fashioned Haldol? Much less side effects. Haldol caused what's called dystonic reactions a lot of times, where people, the worst one is where they get kind of like they're choking. It's called a laryngospasm. They go, and they're like choking in front of your eyes from the medications. Others get something called ocular gyrate crisis, where their eyes roll up in the back of their head. Really spooky, scary looking. They get torticollis, where their neck suddenly twists their head like this. Or they get what's called akathisia. They can't sit still. And the worst thing is that's a side effect of the antipsychotic meds. Some less knowledgeable people will see the person doing that and go, look, they're agitated, give them more antipsychotic meds, which just makes them that much worse. It can also, like that old medicine Haldol, it causes something called dysphoria, or just, it makes you feel, for lack of a better word, it makes you feel like crap. Patients tell you this all the time. They say, I've had patients tell me, getting a shot of Haldol was like, for the next 2 days, walking through a vat of Jell-O. They just felt slowed down and just awful. They had this kind of malaise. It felt life was just miserable. And it's so bad, and I have yet to find a doctor I have said this to that disagrees with me. Patients all the time come up to you and say, I can't have Haldol, I'm allergic to Haldol. And almost none of them are really allergic to Haldol. I don't even know if there's such a thing as allergic to Haldol when it comes down to it. They don't want it because they've had it before and it made them feel terrible, or they had those really bad side effects, or it was just an awful experience. So again, talking about compared to other medical specialties, how often in any other medical specialty do you give somebody a medication that they're begging you not to give them? That you say, please don't give that to me, it's horrible. And yet there's still, it's the #1 med given in emergency situations in the country. Because the doctors say, well, it's good enough for him, you know. I know it works, it's good stuff, you know. It's like, good for you, yeah, but it's not helping your patients. And think of the longer term, and think what they're going through, and think how you make them better. That's, like I said, the patients, they're complaining the way it makes them feel. And the other thing is it causes much less over-sedation to avoid the Haldol cocktail. And why is over-sedation a bad thing? Well, when somebody's unconscious, we obviously can't do an eval, we can't get a history, we can't find out what's going on, we can't help them to have something to eat or drink. For those people who are in an ER, they can't get moved out because nobody's going to take a patient who's unconscious. And you can't help them at all because because they're asleep. And so you're not doing anything for them, they're taking up space that you could be having somebody help in. It's a bad situation all around. It's just not good. So that's why we avoid it. As we mentioned before, other treatments for agitation, if it's not a situation like schizophrenia that needs an antipsychotic med, if it's just drugs, probably we're going to be fine just with Ativan. Again, alcohol, let's treat the alcohol intoxication withdrawal. We're not going to really be using medications. If somebody has delirium, that shouldn't even be we shouldn't even see that in CSU. One of the big diagnostic difficulties, is psychosis versus dementia versus delirium. If people are having symptoms of delirium, they should not have been here in the first place. We can call 911 to get that out. Delirium is life-threatening. Delirium is when people are doing this. because they're seeing things in front of their face, or they're so confused they can't track. It's a big difference than psychosis. If they're seeing things in front of their face, they're having visual hallucinations. No matter what anybody tells you, there's no psychiatric illness that causes visual hallucinations. Disturbances of perception, yes. Delusions, yes. Actual things where they're trying to grab or telling you about a pink elephant or something like that, get them back to the ER. Those are people that we want to get the help that they need. So does all this stuff work? When we created the Project Beta, the de-escalation, the focus on changing the med regimens, the approaches, which our initial thing on it. In the first 3 months after we did it at the test site, people were saying, you reduce the number of restraints, the number of assaults are going to go way up because it's going to be dangerous. Well, we decreased the number of restraints by 43%, but assaults and injuries went down by 58%. That changed that. And it continued to go better. That site now, 2 restraints per every 1,000 patients. What else happened? Assaults continue to go down. Workman's comp went way down. Staff employee satisfaction went way up. People started enjoying the work more. They actually liked not putting people in restraints and actually helping people get better. And the patient satisfaction scores went into the top 10% in the nation. In fact, even to the 99th percentile, which was just amazing. And the insurance costs, like I told you, they were actually based on how much you put people in restraints and the injuries that they got. Those actually went down by 90%, which was just amazing. So we've heard from other hospitals around the world that have implemented this. One of the cool ones, big, huge, the Trauma Center for Honolulu implemented the guidelines, dropped their number of restraints in a medical ER from 20 per month to 0. This is some of the most impactful data. This is from Dallas Parkland Hospital, the same hospital that John F. Kennedy was brought to after he'd been shot, and real famous hospital in Dallas. They implemented this. They reduced the number of coercive treatments by 96% in the first month. And it never went back up. In fact, it just kept going, creeping slowly down. Just by changing that perception, instead of saying, grab them, give them a shot of Haldol, to de-escalation, compassion, collaboration. That's the kind of things that changed. And things that didn't change was the volume or the aggressive of the patients, because sometimes we'll tell this to researchers and they'll go, well, you just don't have dangerous patients like we do. It's like, no. These are the same patients that were just like yours the month before, and this is how it changes, and it's why it changes in a place like this. And another thing was the need for giving people shots versus getting them to take oral meds. You can see one falls up to the floor, the other climbs way up. Just suggesting, being collaborative, not saying you're getting a shot, give them a shot. No reason to screw around, give them a shot. No, let's talk to somebody. Let's encourage them that medication is going to help what's going on with them right now. And people are going to get better. And the staff in Dallas engaged folks. So finally, we made it, and we made it just on time. It's just at 3 o'clock right now. Last year, and I was fortunate enough to be one of the authors on this, they put together international expert guidelines on agitation. People from all over the earth got together, and everybody agreed. Their number one agreement was the main goal of treating agitation is to help relieve the anguish, rapidly treat that agitation, calm somebody, but not knock them unconscious. So it's really the way to go, and everybody in the world agrees. And that's the nice thing about it. So thanks, everybody. It's great working with you today. I'm excited you're all going to be part of this unit. We're going to have a great experience here. So thanks, everybody.